Well, class, here we are. This is our last lecture, our last topic for our human development class. I hope you have enjoyed learning about the prenatal environment and infancy, toddlerhood and childhood, pre-adolescence, adolescence, emerging adulthood. Look how far we've come. Early adulthood, middle age, and now old age. And here we are in our last topic of death and dying. It's unfortunate that human development classes all across the world end on this topic. But, it is a normal part of the lifespan, as we talked about in the last class. So we're going to have a few slides today to talk about, and then that's it. In the last lecture on common health issues in older adulthood, we touched upon some of the more common illnesses, but we weren't necessarily framing that around death. And so I went to the CDC website, and I believe the most recent data is coming from 2018, which is represented here, to see what are the top 10 most common causes of death. And this is specifically for individuals who are 65 and older. If you are interested in looking at earlier times in the lifespan, so what are the top 10 causes of death in adolescence, for example, compared to middle age, that data is also there if you are interested, as I said. So when we look at the top 10 causes of death, again, according to CDC, so nationally representative data, we see that heart disease is at the top. And then we see cancer coming in next, chronic low respiratory disease, which is made up of chronic bronchitis for individuals who have emphysema or asthma, so just respiratory diseases. Then we have people who had issues with basically blood flow to the brain. So these are things like strokes or aneurysms. Quite common. We talked a little bit about that in the last class period. Similarly, we also talked about Alzheimer's in the last class period. Diabetes and complications from diabetes come next, number 6. Unintentional injury is number 7. I'm not sure, I don't remember why CDC has this in blue, but this is one of those that is pretty interesting to compare across the lifespan, because much of childhood and adolescence, and I think even into early adulthood, unintentional injury is number 1, the number 1 major or common cause of death. And so this changes substantially as we get older. One of the reasons is that we're engaging in less risk-taking behaviors. That's a huge part of it, actually. But not to say that the elderly aren't also succumbing to injuries. That happens all the time. I mean, the book that I believe you had to read this part in the book, but about car accidents, and we talked about how as individuals get older, their cognitive abilities could affect their ability to drive. I remember one of the last times I rode in a car with my grandpa. I think I was about 18 years old, and I think he was driving me to a doctor's appointment. I was sick. And instead of driving in between the lines, he did what I call as Pac-Manning. So if you know the game Pac-Man, you're supposed to eat the little circles or the little dots. And so we were essentially driving between two lanes, and he was like driving on top of the dashed lines. Didn't necessarily feel very safe, but we made it there all right. So unintentional injury is very, very common, again, for when you're thinking about a cause of death earlier in our lifespans, but it still plays an important role in causes of death even into old age. We see influenza and pneumonia coming in at number 8. I'm not sure where, for example, coronavirus will play into the data from this year. It'll be interesting to see what that looks like. Not necessarily interesting in a good way, but interesting nonetheless. Next, we have nephritis, which is a kidney inflammation. I just wanted to make sure that everybody knew what these terms meant. And then we see Parkinson's disease, which is something you're going to have to read about if you haven't done so already for the final exam. So you see a lot of these are illnesses, and some of these may have been issues throughout the lifespan. So for example, somebody might have been struggling with asthma for a long time. But a lot of these are coming in suddenly. So, for example, influenza is coming on suddenly, in unintentional injury suddenly. Some of these have to do with lifestyle issues. So, heart disease and diabetes are two that come to mind that, in a lot of ways, although you might have a predisposition for these, but lifestyle changes can really affect one's likelihood of getting one of these diagnoses and or letting that diagnosis lead to the point of death. I think just in general, this is interesting to look at because of all of these factors that are at play. If we're taking a biopsychosocial approach to human development, looking at each of these and how, again, sometimes we do have this genetic predisposition, sometimes the things in our life and our environment are affecting these, and ultimately all of them can be psychological, and thinking about how they affect us and how they affect how we see death and how they affect how we see our loved ones with these diagnoses. So these are some of the things we're going to be talking about for the rest of this lecture. For some of those diagnoses and others, some of these might have been diagnosed, and when they were diagnosed, the doctor or team of doctors noted that they were terminal. So an individual is aware that they're terminal, and or if the person is out, it's outside of awareness. Let's say cognitive facilities have already been lost, that they're again still, the team is aware that it's terminal. So for some individuals at the end of their life, they may choose and or their family may choose to put them in hospice. And essentially hospice is a general approach that is emphasizing dying patients' needs for certain things, which I'm going to get into in just a second. So hospice is typically for the terminally ill and or dying. I guess that's the same thing. So in hospice, then essentially the team of doctors or care providers are helping to make sure that the end of life is as pain-free or painless as possible. So it's all about pain management. It's not about prolonging life itself, as it says in the fourth bullet point there. So if somebody is put into hospice, it's not put into a situation where the attempt is to make them get better or to fix any problems. At the point of hospice, it's really just trying to make sure that the person is having reduced pain to the best of the care team's ability, that they're getting support that they need. So this could be psychological support. There could be psychologists who are working in that environment, or licensed mental health social workers who are working in that kind of environment. There are many people who choose to have spiritual support that is essential during their end days. Social support, that could be, it varies from team to team, but it could be other people who are going through similar situations, or there could be group therapy, or there could be focus on, bringing in families and making sure that the person who is terminally ill is supported. It's all about death with dignity and essentially making sure that people are treated as well as possible and getting the support that they need. So you may have heard of hospice centers, and essentially if you know somebody who has gone to hospice, it is, it's the last stepping stone before they pass. But also we can talk about a hospice approach, because again, it's an approach and not necessarily a location, with, at home with friends or with family. I know that my grandma had pancreatic cancer. This is about, a long time ago now, 14 years ago now. And, it had hit her pretty quickly. And pancreatic cancer is one of the ones that does not have a good survival rate. And so eventually she ended up in hospice. And by the time she was in hospice, it had already had moved to her brain, and so she was unaware of the world around her. Like, she didn't know who I was, and she was calling my grandpa a different name and so on. But I just remember the hospice team there just being so warm and supportive, and her room there was just really comforting. And even if she wasn't the same grandma that I had once known, it was definitely comforting to us also as a family to see where she was. And again, part of that is that my grandpa couldn't take care of couldn't take care of her in their home. But it's just a warm place that even though it's end of life and there are lots of sad and negative emotions associated with that, this was a place that we knew she was being supported. And again, that idea with death with dignity was definitely apparent in that environment. Let's say for people who, it's for a similar approach, but people who don't necessarily have a terminal illness, there's something called palliative care, which is essentially, well, quite often for people with cancer. So not necessarily a terminal illness with cancer, but the idea is very similar, just essentially controlling pain and related symptoms. So really thinking about the patient's well-being and thinking about them from a holistic approach. So again, psychological, spiritual, social, obviously biological as well, but it's a type of care that is really focused on this pain relief and trying to help them through the process in a way that other medical care doesn't necessarily do. Research has actually shown that this approach of palliative care can extend life, and so it's not, again, for people who necessarily have just terminal illnesses. It's common for people who are really ill and aren't doing well, but it's a similar approach to hospice. One of my best friends actually is a palliative care physician out in California, and I think that this takes a special kind of doctor because, it can be really challenging to work with patients who are really ill and who may be struggling in lots of ways. So not just physically, but also these psychological and spiritual and socially. We're going to talk about how for some individuals, family doesn't know how to respond to illness and or disease or death, and so sometimes families pull away and because they don't know how to respond, and maybe this has been something that you've seen in your family or people close to you too. So if you have this care team or this team of people around you who are trying to make sure that this time in your life is maybe, I use this loosely, but smooth as possible. This can make this time in one's life, whether this is end of life and or just during a very challenging illness, more manageable.